In our panel today, we would like to show how injuries and more broadly all other health problems that need surgical care are a major component of the global burden of disease, that they can be prevented and treated in an affordable and sustainable fashion, and that the world of global health should devote more attention and resources to what has been a very neglected field. In my own talk, I would like to review some basic facts about the injury problem, point out that there is much that has and can be done to better prevent and treat injuries, and discuss how to make more progress globally. Around 5.8 million people die each year from some type of injury. This accounts for 10% of the world's deaths, more than the number of people who die from HIV, AIDS, TB, and malaria combined. 90% of the deaths from injury are in low and middle income countries. While usually thought of as more of a problem in wealthy countries, in fact, the opposite is true. Rates of death from injury are actually lowest in the high-income areas of North America and Western Europe. They rise to being higher rates of death from injury in Latin America and the Middle East, even higher rates in Africa and Southern Asia. And then the highest rates of injury-related death in the world are in the currently low and middle-income countries of the former Eastern Bloc. Causes of injury are many. The main ones, the single leading cause is road traffic crash deaths. The next leading cause are a combination of what we call intentional injuries, that is, when somebody sets out to hurt themselves or others, suicide or homicide, and then a variety of other unintentional injuries, road traffic and these others, unintentional or accidental. And it's getting worse. Those three main causes, road traffic, suicide, and homicide, are all anticipated to rise in rank in coming decades. And in addition, many who survive injuries are left with disabilities, permanent or temporary. 16% of all disabilities globally are caused by some form of injury. So we have a giant health problem with minimal attention being devoted to it. In part, this is because of a sense of nihilism among people and among governments that injuries are mostly due to accidents, and hence what can be done to prevent them, and also that their treatment's expensive, and what can we really do to improve upon the existing hospitals and such that we have. Well, in fact, there's a lot that we can do to better prevent and treat injuries. And as just one example of how this can be successful, I show here trends in road traffic crash deaths in the United States over the past century. In the early part of the 19th century, when the automobile was invented, we began killing ourselves with it in mass numbers, deaths per 100,000, to the point where in the 1930s the rates of death peaked, and at this point it had become one of our leading killers, especially among older children and younger working-aged adults. Gradually, through road safety efforts and improvements in care of the injured, these rates have been brought down to the point where now they are at the lowest level that they've been since the 1920s. Obviously, still a lot needs to be done, but progress has been occurring. And this has been achieved by better application of the spectrum of injury control, including surveillance to understand the extent and nature of the problem, prevention efforts such as road safety, and improvements in care of the injured. It is eminently feasible to undertake improvements along this entire spectrum in countries at all economic levels worldwide. To say a few points about some of these issues. First, injury prevention is often misunderstood as merely admonitions to be careful. However, it's a scientific field like that used to approach any other health problem. It includes research into identifying risk factors, developing scientific, effective programs to target these risk factors, and then evaluating the results so that we know, based on evidence, what really works and should be scaled up and continued. To take just a few examples, once again, the major injury problem in the world, road traffic crashes. There are three main domains of road safety: roadway, vehicle, and human factors. Much can be done globally for each component. Roadway infrastructure. A major contributor to road safety is the constantly evolving process of identifying and correcting dangerous sections of roadway. You see here two examples of rigid roadside barriers, one in Mexico, one in Seattle. If a vehicle were to strike either of these objects at 60 miles an hour, there'd be a high chance of serious injuries or fatalities in the vehicle. But by placing a simple energy-absorbing barrier in front of the rigid object, this decreases the likelihood of a serious injury. And much of road safety involves converting situations like this, where you see there's a warning sign, but no barrier, situations like this to situations like this. Now, devices like this can be somewhat expensive, but low-cost alternatives can be easily arranged. From some work I did collaboratively in Monterrey, this is a very dynamic chief of police of the city of Monterrey, Mexico, Alejandro Herrero, who went on this campaign several years ago to identify the highest risk rigid roadside barriers in the city and put very simple, low-cost water-filled barriers in front of them, barrels in front of them, with the result that fatal crashes decreased significantly at these sites. Another aspect of road safety is safety features in vehicles, including features built into the vehicles and features that involve maintenance, which is especially important for older vehicles. In Ghana, most of the transport is provided by taxis and minibuses such as this, often very high occupancy. A few years ago, we conducted focus group discussions with commercial drivers, such as these gentlemen, who revealed some interesting things. They reported that due to high cost, there was a lot of safety implications, that people had to buy very used and jerry-rigged spare parts, tires very bald, brake components often worn out but still used, and some reported that due to the high cost of hydraulic brake fluid, they used a soap and water mixture in their brake linings. All of this, of course, and one can only imagine how this might affect things like stopping distance or risk of fatal crashes for the many people that ride in these vehicles. All of this has policy implications. For example, would measures to increase the availability of higher quality spare parts, safety-related spare parts, be useful? In some cases, this might be done very easily, such as by lowering import duties on these items, as is done in some countries with other health-related items, such as mosquito nets. There's a long list of human behavioral factors that contribute to crashes. Alcohol is one. Drunk driving has been a major risk factor in high-income countries, accounting for 1/3 of all fatal crashes. And anti-drunk driving campaigns have been a cornerstone of road safety efforts in most high-income countries. To what extent does drunk driving contribute to crashes in low and middle-income countries? To what extent should scarce resources be used for anti-drunk driving work? In order to answer this question for one locale, several groups collaborated to undertake what is still the largest random roadside breathalyzer survey yet conducted in Africa. And this utilized methods for such surveys that have been developed and conducted in the United States by the National Highway Traffic Safety Administration. A group of which I was part tested 722 randomly selected drivers with breathalyzers. This is my colleague in the work, Dr. Godfried Eziama from the Ghana Police Hospital. And you see us at the start of the work working with the handheld breathalyzers to make sure that they are well calibrated. And this study had frightening results. If you look at the peak times, that's weekend nights, and the percent of drivers that were dangerously drunk, blood alcohol concentration of 0.1 gram or more, the rate in Ghana was considerably higher than the rate in the United States, either in the past or currently. And if you look at the 24-hour, 7-day-a-week average, 3% of bus drivers were drunk, and 8% of truck drivers were intoxicated. And so if you imagine driving on the Accra-Kumasi Road or other similar roads around the world, that means that if you see things like this whizzing by you, 1 out of 12 of them has a driver that's dangerously drunk, not just a little bit drunk. And that, of course, probably explains why you see many scenes like this. So what to do with this type of information? Publishing it in scientific venues is only part of the picture. Such information needs to be used for real results. And Dr. Eziama wrote editorials about it and presented it to his political leaders. And this information was one piece of evidence that was used to institute a law establishing a 0.08 milligram percent cutoff as a definition of drunk driving in that country, the first time that that was established in Ghana's laws.